The elegant trial looks to switch patients from their standard adjuvant endocrine therapy, which is generally an aromatase inhibitor, and for premenopausal women, an LHRH agonist, although it could be with tamoxifen, after they finished a CDK4/6 inhibitor, if they had a CDK4/6 inhibitor, which most patients will because it's aimed at a high-risk population, to switch those patients over to the oral SERD, elacestrant, and that's regardless of ESR1 mutation status. And with the reason it's an important trial is because we know the oral SERDs are non-cross resistant with standard adjuvant endocrine therapy. The aromatase inhibitors, they're also non-cross resistant. They're effective after CDK4/6 inhibitors. So if there's any emerging resistance to the AI or to the CDK4/6 inhibitor, we know from the metastatic setting that oral elacestrant is effective. And it's equally effective to fulvestrant in the intent to treat population and ESR1 wild type, but it's superior in ESR1 mutant. And this is another important piece because with aromatase inhibitors, you can get emergence of ESR1 mutations, and then the aromatase inhibitors are ineffective, essentially. So this is a way to really switch over to targeting the estrogen receptor in a way that will address some of the resistance mechanisms that may have been emerging during the 2 to 5 years that patients have been on their antecedent AI therapy. So it's very, very important because we want to use our very best agents in the curative setting to basically try to now kill off clones that are emerging that are resistant to the endocrine therapy with or without the CDK4/6 inhibitor. The Monarch E trial and the Natalie trial, our adjuvant CDK trials, did a great job, I think, of defining high risk. And in Monarch E, which is the same patient population in the cohort 1 of Monarch E as the Elegant trials, very high risk individuals, 4 or more nodes, or if they have 1 to 3 nodes, has to be grade 3 disease or T3, T4 disease. That's very, very high risk population. And then Natalie, any node positive patient was eligible, and then some high risk node negative patients as well. So Natalie has an intermediate risk and a high risk population. And then the Monarch E has the high risk population. So the Elegant trial is basically patterned after Monarch E, really going after that very high risk population, get a real answer and get it fast. You know, is elacestrant going to really salvage these patients who have very high risk disease, who have been on standard adjuvant endocrine therapy 2 to 5 years? We're very worried there's resistance mechanisms emerging. Will elacestrant really improve the outcome of those patients? So very, very nice that it's really targeting a very high risk population.